Welcome back to Heart Failure Minutes. I'm Dr. Milica Vukićević, a Harvey scholar at the campus of MGB in Boston, and today we revisit a long-standing challenge in durable LVAD therapy, hemocompatibility. Despite advances with the HeartMate 3 pump, hemocompatibility-related adverse events, especially bleeding, remains a stubborn burden. The ARIES HeartMate 3 trial taught us that aspirin removal reduces bleeding without sacrificing safety. Now, a new analysis from the same trial asks a deeper question. Can background pharmacologic therapy, particularly RAS inhibition, further improve hemocompatibility? To discuss what we've learned and where the field is heading, I'm joined today by Professor Mandeep Mehra, who has led this trial. Where have we come with the hemocompatibility in LVAD therapy? Professor Mehra, before we talk about RAS inhibitors, set the stage. How far have we come in terms of hemocompatibility with HeartMate 3 and with the ARIES program?
Yeah, so hemocompatibility has always been the defining frontier of durable LVAD therapy. With older devices, hemocompatibility failures such as pump thrombosis, strokes, and GI bleeding were really the Achilles heel of mechanical support. Now, the HeartMate 3 LVAD changed all of that, and in the pivotal Momentum 3 trial, we showed that by removing mechanical friction and using full magnetic levitation, including an artificial pulse algorithm within the LVAD, that we dramatically reduced these complications of pump thrombosis, stroke, and device malfunction. Momentum 3 showed that the median survival now surpasses 5 years, irrespective of whether a patient is transplant eligible or not transplant eligible. So, no need of thinking about therapeutic intent with these patients. These improvements were all largely tied to a reduction in deaths related to hemocompatibility-related adverse events. Then came the pivotal ARIES HeartMate 3 trial, which built on that engineering advance by refining how we think about the pharmacological side of hemocompatibility. We eliminated aspirin in that trial and just used vitamin K antagonists alone, and we showed that there was a significant reduction in major bleeding, fewer hospitalizations, lower cost of care, and this was all achieved while preserving event-free survival. So engineering fixed the device blood interface, and ARIES optimized the anticoagulation, antiplatelet therapy interface. The question that naturally follows now is, can we go even further by modifying the vascular and neurohormonal environment in which the patient and the device live? That is where RAS inhibition enters into the lexicon of this conversation.
RAS inhibitors as the next frontier, why might they reduce bleeding? The newly released secondary ARIES analysis suggests RAS inhibitors, AC inhibitors, ARBs, ARNI, and mineralocorticoid antagonists may be associated with lower hemocompatibility-related adverse events. Why would a neurohormonal pathway influence bleeding in LVAD patients?
Yeah. So the signal that we have seen from this analysis from ARIES is quite compelling. But certainly one could argue that it is an exploratory signal because that was not the primary intent of this trial. This analysis from ARIES led by Jason Katz looked at patients who were on RAS inhibitors at the 1 month time point after LVAD implantation. And we showed a much greater reduction in hemocompatibility related adverse events, lower bleeding rates, lower stroke rates even numerically. And if you look at the aggregate, the rate ratio for overall reduction in hemocompatibility related adverse events was quite significant, was 0.63, translating into a 35% reduction in these adverse events. The mechanism was not simply blood pressure reduction. We actually did not find any interaction with blood pressure control in this trial, suggesting that there must be some other biologically plausible reason for this observation. I personally think it might be a few things. The first is that vascular remodeling and angiodysplasia biology are very unique in LVAD treated patients. Chronic LVAD support promotes a very low pulsatile environment and creates gastric bleeding in mucosal surfaces by the creation of angiodysplasia or AV malformations. RAS blockade has actually been shown to reduce pathological angiogenesis. We know this from the diabetes literature where retinal changes have been improved with such therapy. Endothelial proliferation is reduced and shear stress related vascular remodeling is also impacted. I think another way in which this therapy might work is through reduction in inflammation and oxidative stress. RAS activation drives inflammatory pathways that worsen mucosal vulnerability and also amplify bleeding diathesis. So RAS inhibitors may represent an unexpected but very rational and very logical lever to reduce this observed bleeding with LVADs, one that aligns vascular biology with pump engineering.
What mechanisms should we explore next, and what does the future look like? Given these findings, what is the future? How should the field build on this signal?
Yeah, a great, important question, and I think this analysis gives us a scientific nudge towards a completely new direction. So hemocompatibility is not just an engineering problem, it is a vascular biology problem. And what I believe we need to go to next is first to further test this hypothesis of RAS inhibition in LVAD patients. And the Aries analysis is just hypothesis generating, but not definitive. So what we are doing right now is looking at this exact same signal from within the large pivotal Momentum 3 trial. So we're looking back at a trial done before Aries. And if the same signal appears, then we might have a sufficient stage set for a prospective RCT. Momentum 3 has over 2,250 HeartMate 3 patients treated for 2 years. So we should be able to see the signal if one really exists. The second is that we need to try and understand the mechanism of this action by doing mechanistic studies on vascular stability and addressing the biology. Does RAS inhibition in these patients reduce angiopoietin 2 levels? Does it modify AV malformations? Can it restore microvascular integrity? Or does it actually act through von Willebrand factor integration mechanisms through ADAMTS13 balance? What we are really doing is moving towards a much broader paradigm shift, in my opinion. The biggest message here is that LVAD therapy is now no longer just a pump optimization issue. I think that it's an organ system optimization issue, and the Aries RAS inhibition signal is our first step towards such a new integrated model.
Thank you very much, Professor Mehra, for breaking down this emerging frontier. We've come a long way from engineering solutions that reduced pump thrombosis to pharmacologic strategies that cut bleeding. Now RAS inhibition may represent the next chapter, a biologically grounded approach to improve hemocompatibility in LVAD patients. This is Heart Failure Minutes with Dr. Milica Vukićević signing off for now. Until next time.